Hi everyone. We shall continue with the next part of the lecture. So this lecture is going to be covering about the peripheral visual field effect. Okay. First of all, before we move on, what are the training or management options that are available for this? Okay, we'll start off with types of visual field effect first. Okay, like for example, the picture that is actually given at the top left here. Top left here. This is how. Okay, this is a door and this is a living area with a sofa. Okay, this is how a normal people will be seeing this area or this place. So it's clear, but then if you look at patients who are having left homonymous hemianopia, right? Okay, so the door knob will be missing, okay, for them. And then for patients who are having right homonymous hemianopia, they will not be able to see this portion. Okay, half of it's not visible to them. Okay, so this is the problem that patient would have if, let's say, they have homonymous hemianopia. Okay, and another type of peripheral visual field defect would be tunnel vision. Okay, tunnel vision is like an overall constriction of the field at the periphery. So if I say this is the whole city that patient able to, if let's say a person able to see, but if let's say that patient is having tunnel vision, they're only able to see only the center part. So whatever that is at the side would be missing for them. Okay. So these are the two, peripheral visual field defect, how the patient would actually experience. So today's topic, so this video, the topic is going to be on peripheral visual field loss management. Okay, so we're going to look at what are the options of management that is available for this kind of patient. Okay, so there are three types of management that is available, and it actually helps patient with different kind of visual field effect. One is field expander, another one is mirror reflecting system, and the third one is Fresnel prism. Okay, so these are the three management, and we're going to look at one by one. Okay, so first we start with field expander. Okay, what is field expander? It comes in a few forms. So basically, it helps patient with overall constriction or patient with tunnel vision. Okay, so this patient would benefit from this field expander. Okay, so how does this field expander is actually prescribed to patient is in two ways. One is uh, uh, you can take -8 or -10 within the range, high minus lenses. Just take that lenses, uncut lenses, put it at the arm length, and if you view that through the lens, right, more information from the side will be actually, in the lens. So that if, let's say, a patient is looking at this, for example, this is tunnel vision, right? Okay, with their naked eye, patient able to see only this. But if, let's say, an uncut lens is actually, with a -8 or -10 diopter is taken and put at arm length to view this. Okay, what will happen is information from the side will actually can be seen in the uncut lens, so that this patient would have an idea of what is at the site, rather than they just depends on whatever that they can see in the vector. So that's how the field expander will be helping them. So this field expander cannot be prescribed, for full-time view because it's not the real image. So that's why it is usually prescribed as a handheld lenses to the patient. So the uncut lens is actually fitted to a holder, and then with that holder, which will look like similar to a handheld magnifier. So what they have to do is, if let's say they are going into a place, or if let's say they want to scan through, if let's say it's a student who wants to enter in to a library, for example, they just can take that handheld high minus lens, field expander, put it at arm length, and then scan through what is actually, in that walking pathway of the student. And once they already view, and they know that while they're walking around, while walking through the pathway, so they know that these areas are a bit congested, so they have to plan earlier how to actually navigate through the room rather than just barge in without knowing what is awaiting for them. So that is one way. Second one is using reverse Galilean telescope. Is already using a Galilean telescope. They can just use the uh, objective lens. Okay, we use eyepiece to actually be, patient uses eyepiece to look through the telescope to magnify the image. Okay, but if let's say they want to use it as a field expander, they just need to reverse it. Use the hard part, okay, to be close to the eye and then view through, then they can get more information, from the side. So that expands the field of view. Okay, so these are the two ways of prescribing expander to the patients. Okay, so the type of field loss that should be avoided in field expander is hemianopia. Patient with hemianopia will not benefit from this. Okay, and how does it affect on acuity? It actually, when the congest information from the side in one lens, okay, or in the lens of the telescope, so the image quality or the clarity will be slightly lesser. The visual acuity drops a bit. Okay, it's not as clear, but you will get idea of the patient will get idea of what is at the side. Okay, and in terms of the field, obviously the field of view, is bigger. Okay, field is expanded. The visual field is expanded because more information from the side can be viewed by the patient. So we binocularly, binocularly. And the fitting is if patient is already using a Galilean telescope, no issue. You just need the telescope. If let's say a patient doesn't have is the okay, can actually have a handheld minus lenses. Okay, as I say, just take an uncut lens and get a holder for it, and that can be prescribed to the patient. Or another way is if let's say the patient is wearing spectacles, they can have actually, like for presbyopic patient, right? Like the pocket size of reading edition that is actually fitted on the lenses, right? Also, the same can be actually fitted to the patient at the superior part of the lens. Okay, at this area of the lens, okay, that field expander power can be embedded in over there. Okay, so when when the power is embedded over there, so whenever they want to scan the place, they can just slide down their spectacles, look through the superior part, the portion of the field expander that is being embedded in, and then once the scanning is already done, they can put back the glasses, and then they can go into the room or wherever they're intended to go. Okay, so that is field expander. Okay, basically it is good for the patients who are having tunnel vision. Okay, so that is a field expander. Next is mirror reflecting system. Okay, mirror reflecting system. It is similar to the function is similar to, okay, while you're driving right at a corner. Okay, while you're driving at corner right, uh, the usually on the road there'll be one mirror that is placed. Okay, mirror that is actually facing the other side where you will not be able to see whether a car is coming from the other side or not. So when you want to take a turn or when you want to move, you just need to look through the mirror to see whether any car is coming from the other side or not. Okay, so the similar method is used for patients who are having hemianopia. Okay, especially the one involving the temporal field. Okay, that means temporarily the visual field is affected. Okay, so there is a scotoma kind of thing on the temporal field from the both side of our eye. So what will happen is we can actually fit a mirror on the frame. Okay, similarly to, it is not as big as the mirror on the road. Okay, this one is more like a mirror um, in the size of a nose pad. Okay, in the size of nose pad, which is actually bulging out. Okay, which is bulging out, not internally, bulging out, placed at the nasal, facing, the mirror is facing the temporal field. So whenever patient wants to scan through what is actually coming from the side, they just need to turn their eyes, look at the mirror to see if, let's say, what are the things at the side. Okay, so that's how it is actually fitted on. Okay, another way of actually fitting this mirror reflecting system is if, let's say, the patient is actually, excuse me, if, let's say, the patient is actually working in a cubicles, right? So usually people get, if, let's say, in cubicles, and people do, the colleagues do approach them from the site and all that, right? So this kind of patient, they will complain of getting startled when people are approaching from the side and all that. So what we can do for this patient is, okay, we can ask them to place a mirror that is actually, facing the temporal field. So whenever they feel like, they should know what's happening, at the temporal, or if, let's say, they have to look at, if, let's say, there's something coming from the side, okay, they just can look through the mirror rather than turn their head, to the fullest to get the information from the side. So that is the way of actually, a mirror reflecting system works in managing patient with uh, peripheral visual field defect, especially the one who are having amyotropia involving the temporal field. So this management is not benefiting patient with tunnel vision. Okay, and also the effect on acuity, because it's just a mirror reflection, so the visual acuity is not affected, but the field of view will be expanded. Okay, because objects from the non-seeing field, the temporal field that cannot see, reflected by the mirror to appear superimposed on seeing field. That means whatever that you are seeing is based on the reflection on the mirror. So when you want to look at what is at the side, you just look through the mirror and you will see what's happening there. Okay, then when you turn your eye straight, okay, then you will see the real image. So whenever it is needed, then you turn your eye. Prescribe monocularly or binocularly is depending on the condition of the patient. If, let's say, patient have both eye hemianopia at the temporal side, then both eye need to be fixed with the mirror reflecting system. Okay, with the mirror on the lenses. Okay, then how do we fit this? Okay, so we fit on the side of the spectacles furthest from the defect. Okay, the defect now we are discussing is the temporal one. So we have to fit the mirror on the nasal part. Okay, but it should be facing the defect area so that the image is reflected from the defect area. Okay, so that will be the another management of peripheral visual field defect. Okay, the third one is Fresnel prism. Okay, the pronunciation of this prism is very important. S is silent. It is not Fresnel prism, but it is Fresnel prism. So this Fresnel prism is, okay, it is how does it look like? Okay, this Fresnel prism we do have in the clinic. The Fresnel prism looks like a, if you could recall back during your school days, there is a, you have to submit assignments, for your projects and all that, right? So there'll be one, when you bind the book, okay, there'll be one transparent layer that will be actually attached on the first page, right? So that, the inner pages doesn't get dirty. So that's how the Fresnel prism looks like, but in a more softer version, okay? So this Fresnel prism, right, it comes in gratings, and that gratings has value for the prism power. Okay, so this grated, kind of transparent sticker kind of thing. Okay, that's how it looks like a very soft, a plastic. Okay, so how does this thing work is this one, you just need to cut, that Fresnel prism according to the shape that you want and all that. You just need to cut and stick it on the spectacles so that the image can be, shifted to the image of the non-seeing area is actually, shifted to the center area so that you will be able to see. So it can be actually, uh, stick to the spectacles in a very easy way. So this, you just need to immerse the lenses and also uh, the cut. I mean the Fresnel prism which is already cut according to the shape of the spectacle. Just immerse in water and then you paste it and then you let them dry. Okay, and then it will be good. Okay, so it will stick together. So when you want to remove the Fresnel prism, also the same. You just need to immerse in water and then you just remove the sticker, okay, kind of thing, then it will be removed. So it's this Fresnel prism is very good because it benefits patients who are having homonymous myopia and also panavision, but it does not actually benefit patients who are having upper or lower altitudinal defect. Okay, upper altitudinal defect usually it's the beginning stage of glaucoma. Okay, so how is it affecting on acuity? It is slightly decreased. Okay, why is it decreased? For example, if let's say the patient is looking at this hemianopia word, for example, okay, so the patient is looking at this area. So with the help of the Fresnel prism, what will happen is, okay, this overall word will be actually shifted. If let's say the um, patient is having homonymous hemianopia at the temporal. If let's say they're having hemianopia at the temporal field, what will happen is, okay, so once the Fresnel prism is already stick to the lenses, what will happen is this overall word will actually shift to the, somewhere here, okay, next to the hemianopia, or maybe, maybe okay, so somewhere here. So this image will be actually shifting to here. Since the image is actually, shifting closer to this word or overlapping to the word, right? So what will happen is patient will have slight confusion because this overall word which is actually shifted to this area because of the use of Fresnel prism, okay, it will confuse the patient because it will be overlapping for the patient. Okay, in terms of image, and it is permanent. It is not something like things is that, right? For example, if I read avoided, so this hemianopia will be overlapping with half of this avoided word. So whenever you shift your gaze, when the patient is shifting their gaze, right, the imaginary image is also changing. So in the beginning, patient will have a lot of confusion because they know which one is the real image, which one is the imaginary image. So whenever it is actually, moving the eyes, the confusion is there all the time. But it will take a few weeks only for patient to get adapted and for patient to know which one is the real image and which one is the imaginary one or the one that is caused by the shifted uh, image based on because of the Fresnel prism presence. Okay. So that's how this Fresnel prism is prescribed. Okay, and the effect on acuity slightly decreased because the clarity is gone because of the overlapping of the image, and then the effect on field will be obviously good because it expands the field. Now, rather than they're not able to see whatever that is here, now at least they're able to see a few words that are coming to the center. So the field of view is expanded. Okay, next, whether it's prescribed monocularly or binocularly, uh, it is actually prescribed monocularly and binocularly. depending on the need of the patient. If let's say both side is affected, then they will prescribe to the both side. If let's say only one side, then it is only one side. Okay. So the fitting, it will be, okay, where do we fit this? If let's say, for example, the example of, to explain this is the example case will be homonymous temporal hemianopia, for example. Okay, homonymous temporal field. Okay, so what will happen is these two sides cannot be seen by the patient. Okay, so how this Fresnel prism will be fitted is the Fresnel prism will be fitted to the temporal side, the right side temporal and then left side temporal side. Okay, and the prism, so basically it is actually fitted on the side that is nearest to the defect. Like mirror reflecting system is towards it is actually fitted away from the defect side, but Fresnel prism it is on the defect side, but yes, sorry, explain again. Okay, so this Fresnel prism is fitted on the defect side, which is temporal, in this case temporal and temporal, and the base is also towards the defect side. Okay, so that whatever image that patient will be shifting will be from the side, then it goes to the base, and the base will actually bring the image to the center. Okay, so not really center, but near to the midline. Okay, it is not like this. When I'm reading hemianopia, this overall word will not actually overlap to the hemianopia. Okay, either it shifts to the side or shift to half of this words maybe. Okay, so it is nearer to the midline. So where do we fit this is on the back surface of the spectacle lenses. So that's where we will be fixing the will be fitting the Fresnel prism. Okay, so this is how it looks like. As I mentioned earlier, this is a field expander uncut high minus lenses, which is actually put in a holder, and then patient able to actually scan through and then keep inside the pocket. Okay, the next one is patient who is actually using this mirror reflecting system. So as I mentioned here, so a mirror is actually placed here, okay, for them to look through. Okay, so if let's say this example is only one side, this one can have more than one. Okay, depending on the defect. Okay, next one is the Fresnel prism. So as I said, it is grated. Okay, it is grated and stick to the spectacles depending on the need. Okay, so this example shows that the patient is fitted with Fresnel prism on the temporal side. So we can expect the patient to have hemianopia at the temporal side. So that's why it's fitted here, and the base is expected towards the peripheral also, towards the temporal side. Okay, to refract the image from the temporal, so that it's positioned at the center. So these are the examples of the examples for peripheral visual field defect management. Okay. Okay, now before I conclude, one thing that we have to remember is when it comes to this visual field defect management, right? It is not like prescribing low vision devices for the patient. Okay, low vision devices for the patient, right? Depending on the need of the patient. If let's say patient wants to do this with spectacles, they are not able to do even after we give correction. So we can actually suggest to them, we have telescope, they can try that. If let's say it doesn't work for them or they can achieve the target, then we reject that. Okay, so there's no other conditions that we have to actually give concern before we actually trying on them. Any age range Whether they have motivation, they don't have motivation, whether they're old, whether they're young, doesn't matter. We actually attempt on everyone. But when it comes to patients who have peripheral visual field defect or central visual field defect, right? There are a lot of concerns that we need to give consideration before we suggest to them. Like, for example, number one, okay, if let's say the patient is young, then it's very easy for us to actually, train the patient with this, like either eccentric viewing training, whether it's a mirror reflecting system, or if let's say, there's handheld, high minus lenses as a field expander or prism. Okay, because for them, there is a need for them to actually have this so that they can get the information that they cannot see. While older generations, they don't have the need mostly. Okay, one is they don't have need. Number two is they're not motivated like younger people. Okay, younger people, there is a need and then they want to achieve that, so they can actually adapt to this because they're highly motivated. But elderly patients are not like that. Okay, um, like for example, uh, when smartphone boom into the market, right? When there is at one point of time, everybody getting smartphones, okay? Shifting from the Nokia phones to smartphones and all that, right? So in the beginning, the parents had so much of difficulties. They don't know how to actually handle it. When we say WhatsApp, they still want to go on with calls and all that. So they don't know how to actually, use this device, okay, the smartphones. But now it takes time for us to teach them, to use a device, to use a WhatsApp messages, okay, how to actually unlock the phone. All that were difficult. I'm sure everyone gone through this, how the handling parents in using smartphones and all that. Okay, and they are not, if let's say you teach the same thing to a kid, right? Even if it's a 5 6 year old kid, okay, when you teach them on how to unlock and all that, they know how to go to YouTube and then, play the videos that they want, how to skip, advertisement. They learn quickly compared to the older generation. So older generation, they take time, and then they always find like this is actually very difficult. But the kids, they are very easily, they can learn things, explore, because they have interest, highly motivated. Okay, so they are doing it, and they're young, very fresh mind. But older generation is different. Okay, they're tired all the time, they think, this is useless. So these are the factors that we need to take into consideration when we teach them with eccentric viewing training, or when we want to try these devices to them. Okay, if they really need, then only we go for it for elderly patients. If let's say they're young, then we can actually, just try on them. Sometimes they don't like it when we explain, but when they experience it by themselves, right, then they would actually go for it. So that is one, that point that need to be considered before we, suggest to any patient. And then the next one is the cosmetic appearance. All this has a very bad cosmetic appearance. Okay, even eccentric viewing training is very obvious. When we train them, while they're talking to someone, they will not have eye contact. They will be looking at somewhere else and then talking to the patient or looking at things. So this might not, cosmetically looks good. Similarly to the this mirror reflecting system or this Fresnel prism, right? It's very ugly. Okay, even to bring this out and scan through, in a public area, that is going to be cosmetically not very good for the patients to use, but can be attempted. Okay, we can tell them, we can suggest them. Okay, but one thing that you have to be very honest with the patient is you just let them know. Okay, this eccentric viewing training will have this. When a person, a stranger look at you, they might able to judge that you are having some vision problem. If let's say that is okay for you, as long as you can see, you can do your job, your daily task can be done without much hesitant. Okay, then this, you can go for it. If let's say you're still concerned about what people think, cosmetic appearance and all that, then you can, discuss first, you know, give a thought, and then you come back to me when you're okay to actually start the training. So that also can be, that freedom of making decisions should be given to the patient, even if it is a younger patients also. Okay, just let them know, especially the teenagers, right? Just tell them that this is going to be this, and when you go to school, you might get bullied, or people will look at you differently. Okay, or a lot of things that need to be discussed with the patient before we try on this, or after already try, patient is happy. You have to let them know these are the consequences that you need to face by having this. Okay, so that need to be discussed with the patient before you start uh, suggesting the or training the patient with the training, eccentric viewing training, or this peripheral visual field loss management. Okay, so always remember that we in low vision consultation, we also do give some management for patients who are having visual field loss. It's not only about correcting the vision to have a better clarity, but we also give concern to patients who are having visual field defects, because it's a very common thing among the patients to have visual field defect. It's either central scotoma or central visual field defect or peripheral visual defect. Okay, most of the patient would have this. Okay, so that is the reason why we included this in the syllabus, so that you are aware of the management for the visual field defects that the patient is having. Okay, that's all for the video today. Thank you so much. See you in another video.